Pancreatic cancer is difficult to diagnose early, hard to treat, and fewer than 10% of patients with cancer of the pancreas survive beyond 5 years. However, recent progress in the diagnosis and treatment of pancreatic cancer will help make patient care safer and more successful. Ongoing clinical research is the way to better outcomes. On this week's Health Talk, the Director of Cancer Research at Nuvance Health will join me to discuss the important strides being made in pancreatic cancer research. So stay tuned, we're up next. Hello, I'm Dr. Eric Mazer. Today our topic is pancreatic cancer research. My guest today is Dr. Richard Frank, Director of Cancer Research at Nuvance Health. Dr. Frank is also a hematologist oncologist with the Whittingham Cancer Center at Norwalk Hospital. Rich, so glad to have you back on the show. Rich is one of my favorite people and one of our favorite guests. You've been doing cancer research since you got here to Norwalk and while you were in your training at Sloan Kettering. But pancreatic cancer is really a tough one, isn't it? What's the problem we're having with pancreatic cancer?
I think the first problem is that it presents and manifests itself late in the course so that it's diagnosed after a patient has been to the doctor numerous times, typically for a routine problem, abdominal pain, altered bowel function, dyspepsia, they don't feel quite well. Maybe they're diabetic and the sugars are getting out of control. Routine things for which the doctor says, we'll do this, come back, and that can go on for 6 months or a year.
So we often don't pick it up as early as we might.
That's right.
We might pick up breast cancer early with a mammogram. Are there any early diagnostic techniques that are showing promise?
Funny you should ask.
I know you're studying that.
So we started the first national clinical trial looking at individuals who are over 50 years of age and who have new onset diabetes, especially if they all of a sudden have diabetes and they're losing weight. There's about a 1 in 150 chance, so a little less than 1%, that person will have an underlying pancreatic cancer driving the diabetes.
That's really it. Now, what's the mechanism of that? That's sort of interesting.
Yeah.
Is it due to the stress of the tumor?
Right.
Or is it due to some problem with the insulin production itself?
Right. So again, we're talking about tumors that are now maybe microscopic or less than 1 centimeter. So if we can find them, the cure rate's very high. So it's probably not enough that it's putting physical stress on the pancreas, but it's probably secreting substances into the blood that mediate insulin resistance. And so we're also looking for blood biomarkers.
That's very interesting. Yeah, because we think of biomarkers like PSA for pancreatic cancer, the ovarian cancer. So tell us a little bit about the research you're doing for pancreatic cancer.
Right. So even though I'm a medical oncologist and I treat cancer that needs to be treated, I'm trying to spearhead a clinical trial where those individuals with new onset diabetes after 5 come in, they get an MRI of their pancreas, they get blood taken, and we take their blood every 6 months, they get an MRI every year for 2 years, because that's the peak of the pancreatic cancer. We also have a study for families that have a high incidence of pancreatic cancer in them, individuals or may have a genetic mutation.
And that's really interesting because it's not, at least when I studied it, pancreatic cancer was one of the you thought of as typically genetic.
Right.
And yet,
right.
I remember a patient of mine who had Hodgkin's disease and a strong family history of pancreatic cancer. He ended up developing metastases in his liver. We thought it was Hodgkin's disease, we biopsied, and it was pancreatic cancer. So tell us a little bit about the families.
Right, so about 7% of patients diagnosed with pancreatic cancer have an abnormality in a gene called BRCA1 or BRCA2 or related genes.
Now those are the breast cancer genes.
That's right, they were discovered as being hereditary risk factors for breast cancer. So women who have those mutations develop breast cancer or ovarian cancer at an early age. But they also have pancreatic cancer, and the men especially have prostate cancer.
Wow.
So we know a lot more about the cancers that individuals can get, so we're trying to develop screening tests for those earlier.
Do you have any preliminary results you can share with us? Have you made the diagnosis of pancreatic cancer in any of the patients that you were following?
We have made an early pre-cancerous lesion in a man whose both parents had pancreatic cancer. And he had a Whipple procedure here by Dr. Shoup, and he's so far doing well. So I think we saved a life.
So that's one life saved.
But we need a lot more participation, especially in those who have diabetes, because it's one thing to be told you have diabetes, it's another to be told, oh, you may also have pancreatic cancer. It's scary.
Yeah.
And again, 99% you don't. But why not partake in a study that could save your life and will definitely help other people? And so we're trying to get other physicians to talk to their patients.
No, I know the answer to this, but I'm sure people at home are saying, well, why don't we just screen everybody with an MRI once a year or every 6 months?
Yeah. Who's going to pay for that?
Yes.
And also, you don't want to do a test unless there's a very high probability. So we don't want to create false positives. We don't want to create problems. Go looking for things that we have to then attend to that the patient never would have needed to, right? So we don't want to create problems. So
that's the problem with
carefully.
imaging that a lot of people don't realize. I know it comes up in the lung cancer screening programs all the time. You find something in the lung.
Yeah.
You're not sure what it is, but now that you know it's there, you feel that medically you're obligated to go
I always
after
tell patients the only normal CAT scan was the one that wasn't done.
That's a good comment. Because I mean, if you look, you will find something wrong
Always.
with all of us.
Correct.
Which unfortunately is the state of humanity. So we don't generally screen, but we should have a higher, anybody else who is particularly at risk for pancreatic cancer?
Yeah, so I think the first group of patients that are going to be approved for screening are those with a strong family history or who have a BRCA mutation and a father with pancreatic cancer. If you have 2 first-degree relatives, mother, father, sister, brother, eventually I think there will be a blood test, but in the meantime, it's possible to get approval for an MRI or an endoscopy, or at least join a study. There's other national studies being run where such individuals should look to join a screening program. Mm-hmm. So it's the high genetic risk that's going to go first, I think.
So you should know your family history. That's very important, and discuss that with your doctor, and realize that pancreatic cancer is on the list of genetic diseases.
And right now, it's just been officially approved by all our societies that if you have pancreatic cancer of any stage, you should be tested for a BRCA mutation.
Well, that's really interesting.
And if you're not, then you're not getting the right health care. Yeah.
Are there any other genes associated with pancreatic cancer that we know of, less common ones than BRCA?
Yeah, there's BRCA1, BRCA2. There's a gene called ATM. There's other minor ones we don't need to go into, but there is a whole panel. So right now, if you go in for hereditary genetic testing and you meet with a genetics counselor, they won't just run one gene. They'll run a whole panel of 50 genes. Mm-hmm. And the cost is not very high. Most insurance companies will cover it. But if they don't, it is $250, the maximum that you'd have to pay to get a whole panel done.
Now, this is something different than Ancestry.com or one of these?
It's much better, yes. It's specifically looking for the 50 most common hereditary cancer
So
genes.
who would you recommend go in and get this genetic counseling and this testing? Anybody with cancer in their immediate family?
Yeah. I think especially if there's family cancers that are, if a person has cancer and they're under 50 years of age, that's a red flag. If there's more than one type of cancer in the family, or if both father, mother, sister, brother, if there's family cancers and they have questions, they should speak to their primary care about a referral to a genetics counselor. And they can assess the risk and recommend or not testing.
That's really, and this is a change that's now availing ourselves of this new technology, able to tell whether or not you have these specific genetic defects. This is something people can really help themselves with. It's a really very useful information, I think.
Yeah, 23andMe does cover a lot of these, but not with the same degree of certainty. So it doesn't replace the official
So if you have cancer in your family,
and
particularly young members, first degree, you should get yourself a genetic counselor. How do you do this? So
even if there's prostate cancer in the family, BRCA, as we were talking about, these genes also predispose to prostate cancer. So if there's cancers in your family or a known genetic mutation, you absolutely need early prostate cancer.
Which, how do they call any of the cancer centers at their local hospital? So they could call the Whittingham Cancer Center or elsewhere.
That's right.
And ask to speak with a genetic counselor. Do they need a physician referral?
They don't.
They don't. Okay, that's important information for folks at home. We only have a couple of minutes left, and I still want to mention that there's also research in treatment and chemotherapy. Tell us a little bit about that, because it's not a disease that has been particularly amenable to chemotherapy or some of our traditional approaches.
Right. So the main approaches to any cancer are with chemotherapy, and there have been major improvements in that for pancreatic cancer, both before and after surgery, if that occurs. Targeted therapies, there's a gene called RAS, which is a major driver of cancers that has been impossible to block. But now there's a new drug that is in clinical trials that we are running here and at Danbury Hospital. If you have a specific RAS mutation in your cancer, you're eligible for this trial with this new pill.
Now, how do you find out about the RAS mutation?
RAS.
I'm sorry, RAS.
Yeah.
I wasn't hearing you right.
Yeah.
So it's a RAS mutation. How do you find out about it? Will the pathology department automatically do that? Do you have to request the surgeon to do that?
Right. So whenever we have a patient with an advanced cancer, we do two types of testing. One is germline hereditary gene testing from the blood or saliva. The other is from the tumor. That's called somatic or genomic testing. Then they'll test 500 genes related to cancer. One of them will be RAS for certain.
So this is done automatically?
No.
It needs...
You need doctors who are really pushing every envelope. And it's being recommended now for most patients with advanced cancer to have genetic and genomic
Rich, do
testing.
you need fresh tissue for this, or can they take
Nope.
fixed tissue that they have in storage to do this?
Most patients do not need a repeat biopsy. Now, we've been able to run our genomic testing at Sloan Kettering. They have a platform called MSK Impact. And there's other companies have testing called, one is Foundation Medicine. They have a very good test. But we think the MSK Impact is really superior. So our patients are able to get their testing done on that platform for genomic testing, which is a great advantage.
You know, I can't emphasize to people at home how important it is, because there are so many new therapies that are being developed and have been developed recently that target some of these specific genetic abnormalities, and they are, in some cases, remarkably effective.
Absolutely.
This is a whole different era of oncology than I practiced 15 years ago. You're smiling because it really feels quaint and old, like old black and white silent movies.
Well, I'm thinking, 15 years in the future, if I'm there and someone else is here, what am I going to be saying? Same thing. But
that's exactly right.
That's true.
I mean, it's really, so this is really important information for folks at home. How about, again, we're running out of time, but how about other new approaches? Surgical approaches, you said we're doing more surgery now.
So I mean, most people do, when they're diagnosed with pancreatic cancer, 80% are not able to go to surgery because it's too advanced. But about a third of those patients, if we give them chemotherapy or possibly radiation as well beforehand, we can reduce the cancer to enable them to go to surgery. And that's more commonly being done. So there are advances in allowing more individuals to have that Whipple procedure.
Well, that's a lot of good news for a really bad disease. And it sounds like we're really at the threshold of really moving into even some better news, especially as we get a hold of some of these driver mutations.
Definitely.
That's all we have time for right now. I want to thank my guest, Dr. Richard Frank, for joining me on the show. Thank you for watching. If you have questions or comments, please email them to us at healthtalk@newvancehealth.org. Please keep watching. Bye-bye.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
145 over 92.
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.
We are living in the most exciting time in cancer research history. State-of-the-art technologies, a detailed understanding of the molecular drivers of cancer, and new targeted therapies are revolutionizing and personalizing cancer therapy. Dr. Richard Frank, Director of Cancer Research at Nuvance Health, will highlight some of the latest research successes in the prevention, diagnosis, and treatment of cancer. So stay tuned, we're up next. Hello, I'm Dr. Eric Mazer. Today our topic is a very exciting one, progress in cancer research. Joining me is Dr. Richard Frank. He's Director of Cancer Research at Nuvance Health. Dr. Frank is also a hematologist and oncologist with the Whittingham Cancer Center at Norwalk Hospital. Rich, thanks for joining me.
Thank you.
You know, we've been involved in cancer research our whole career, and I must say back when I was a practicing oncologist, it was a little boring. We kept taking the same drugs and mixing them in a little bit different ways and getting marginally the same results. Things are changed now. What's going on? It's really, this is the dawning of the new age for cancer. I think a lot of people actually at home have no idea how much progress is being made in cancer therapy.
Correct. Well, as soon as things improve, people take it for granted, right? But I think in your era, primarily there was chemotherapy, which can cure some cancers, testicular, lymphomas, and we still use it, and breast cancer. And then came what's called targeted therapies as we discovered the genetic abnormalities that drive cancer.
Yeah, the 70s, 80s, and 90s were characterized by this extensive research into what's going on genetically with cancer, but now we have ways of interfering with that stuff that's going on, which is, I think, to find amazing. That's what we mean by targeted.
Right, targeting.
These are the silver bullets.
That's
I
right.
get so
That's
excited
right.
about it. The silver bullets that are able to turn off cancer-causing genes.
Exactly. I mean, the first one was leukemia called CML, chronic myelogenous leukemia. There's a drug called Gleevec or imatinib that targets an aberrant protein in the CML. So you take a pill and you're essentially cured in most cases. Previously, it was a death sentence.
If I may say, this is a little personal note. The reason I went into hematology, my father-in-law developed CML when I was a freshman in medical school. And he died, Rich will know what this means. He presented in accelerated phase and he died 6 months later. The thought that today there is a pill that might have saved his life. I mean, my understanding is people with CML today are living pretty much normal lifespan because of a pill with minimal side effects. You don't lose their hair. This is amazing progress. It's not a common disease, but just think of just the thought of that is awe-inspiring.
Right, so that's happened to some degree across all of cancer. And most cancers now have associated with it the treatment with a targeted therapy of some sort. So some of those targets, if you hit them, the cancer can be cured, like CML. Others, the cancer can go into a better remission or a more prolonged maintenance phase. It's not that no one wants to cure cancer, it's that some cancers have many more defects. CML has one defect. Lung cancer has 50.
I was just going to say that I talked to the T's about the drivers of cancer. And CML, we were lucky because there's a single driver. You turn that off, you cure the disease. But at a lot of these, there are multiple drivers working, and we don't have necessarily attacks for all of them, but we have it for a lot of them.
Right, so even a very difficult to target molecule called RAS, we're running a clinical trial of a new inhibitor of RAS that can drive pancreatic, lung, colorectal, many other cancers. So it's important for patients to know their genomic profile of their cancerous tumor. And we also talked about knowing...
That's new too, just the idea of profiling a tumor. And what does that mean for the layperson at home. Because I thought, again, in my era, you would get it, you'd look at it under the microscope, you'd say it's an adenocarcinoma of the pancreas. That was, you profiled it.
Right.
That was it.
No, now you send it out to a particular place, whether it's Sloan Kettering for a specific test or a company that runs what's called genomic testing. That's a profiling of like 500 genes related to cancer. Within those are all the known targets.
And so they're looking to see which switches have been turned on and are driving your personal cancer.
Correct.
So
we can use a drug that may be used for breast cancer. We can use it in gastric cancer, for example, if someone has a similar mutation, but the drug is approved for another cancer. There's just a lot of that testing going on. So at the individual DNA level, that's been the second major advance. The third has been an immune therapy. So these drugs have really revolutionized cancer over the last 5 years. Drugs like Keytruda, which Jimmy Carter is taking for melanoma, metastatic melanoma, again, used to be a death sentence. Now it's, in many cases, survivable.
Yeah, I was just, melanoma used to scare me more than almost any other cancer because it was unpredictable. It metastasized everywhere, and it didn't respond to anything we did.
Right.
So to think that it responds to this immunotherapy, and I must say, this is a different generation of immunotherapy than the immunizations we thought of back. This is not taking the tumor up, grinding it up, and giving it back to the patient.
Right.
This is really manipulating the immune system, because we figured out that a lot of tumors hide from the immune system.
Correct.
And we now know how to turn that hide to uncover them.
So it's almost too simple. The immune cells are near the cancer, but they cannot engage because the cancer is blocking it. These new drugs, which you can get IV once every month or every few weeks, often with few side effects, sometimes there are side effects, they unlock that block so those immune cells can go right in there and attack the cancer. It's that simple, the mechanism, and the scientist James Allison just won the Nobel Prize for it recently.
He deserves it.
It's revolutionized a lot of cancers.
Why can't we treat every cancer that way? I'm sure people ask that.
Again, the immune system recognizes every cancer differently. Pancreatic cancer does not benefit from this at all. Prostate cancer, very minimally. Sarcomas, other brain tumors, no. The major ones are lung cancer, for example.
Well, again, a tumor that, except for small cell lung cancer, used to be marginally treatable at best.
That's right. And now, so we had people who were dying, and then these immune drugs came. And if you have an excellent response to it, there's about 20% of patients that can live 5, 10 years going on now. It's remarkable that.
But you take care of these patients.
Yeah.
What's it like for them? Because really, they must at the beginning have thought they had a death sentence, measured in months or a year or two, and then to find themselves alive 5 and 10 years later. What do they say to you?
Well, it's different because those patients were there at the beginning when we didn't even know. We couldn't be that hopeful. It was, you may respond, you may not, this is pretty new. And so everyone was learning at the same time, and patients were benefiting. Some were being brought back to life and surviving. Now we're already 5 years into it, so we can tell people that there's a good chance if you respond to it, you're going to have a very good response. And after 2 years of treatment, we're going to stop. And your own immune system is going to still recognize that cancer. So that's different than drug therapy, right? We are reprogramming a person's immune system. So there's a lot of combining immune therapies and combining immune therapies with targeted therapies that's making cancer care and research much more complex even. Then there's the addition of cellular therapy, something called CAR T-cell therapy.
Another amazing treatment.
Right. Then a person's immune cells are taken out, altered with a viral DNA that makes the cells, the genes of the cell express certain proteins that make it now attack their cancer, revolutionize the blood cancers, lymphoma, leukemia, not yet the solid tumor cancers, but it's coming.
Now the CAR T-cell therapy, those cells are programmed in the laboratory for the patient's specific cancer. So which is, again, if you take a step back, this is sort of breathtaking technology, breathtaking science. They're taking the patient's cancer, they're taking the patient's immune system, they're going to the back room and programming those cells to detect the cancer and then giving them back to the patient. And we're seeing cures. My understanding I know it's a toxic, very expensive therapy.
Yeah, it's getting better.
But we're seeing cures in patients that were incurable.
That's right, for sure. Yeah, it's life-saving. And there are a lot of, so we're doing a lot of research in early phase trials. It's called phase 1 trials, especially in something called triple-negative breast cancer. That's a particular type of breast cancer that is very virulent, doesn't respond to immune therapy or hormonal therapy. And so we have a leading expert in that, Dr. Vadat, who is leading a lot of early phase trials in triple-negative breast cancer. So there's a lot of progress in that. So we have a lot of
Is it targeted therapy in that as well?
All targeted therapies, yeah.
So if you have the misfortune to be a cancer patient, you should be seen at a cancer center where people are familiar with cancer center genomics and targeted therapy. This isn't something you should be doing out in the wilderness.
Yeah, but I think there's still certainly sometimes a bias to say this is only going on at certain centers. We have an affiliation with Sloan Kettering at Norwalk Hospital, but even before that, we were
that's the
doing,
other thing that that's important to emphasize, Rich. I think in the old days, there wasn't the kind of diffusion of expertise that we now have. The community cancer centers, I think in many ways, well, I shouldn't editorialize, I think give you more personal therapy.
Much more.
Because
they
know you better.
Well, like you said, there's such an explosion in knowledge to be a competent oncologist, and everybody who's practicing is competent, right, takes a high level of knowledge. So everybody is aware of all this testing. I mean, there can be differences in what's being offered. Certain oncologists may not be so eager to do the genomic testing or the genetic testing. Some of us are a little more forward-thinking. So it definitely helps to get a second opinion, make sure all the proper testing is being done. But all these treatments are being offered in your community cancer center.
And I'm sure you do this. I certainly did this when I was practicing. If there's a treatment, say a bone marrow transplant that you don't do here, but they do them at Sloan Kettering, and that's the right treatment for your patient, you're not going to keep that patient. You're going to send your patient there for that therapy.
All the time we do that. But it's also very foolish to travel for a treatment you could get conveniently in your
generally, if you're practicing, if you're seeing an oncologist who is knowledgeable, they are going to send you. If you need to be sent out, you'll get sent out.
Yeah, and there's plenty of places to get a second opinion also. So clinical trials are going on, and in many different areas of cancer medicine. I think if the facility you're at runs clinical trials, they're up on all these new tests and the type of drugs that we're using.
Rich, we have just 15 seconds left. Can you further characterize the state of cancer research today?
I think very hopeful, very dynamic. I think exploding. And probably there'll be another major breakthrough within the next 5 years that's going to convert all the other cancers we can't treat too well into highly treatable cancers. So very, very cheerful.
Again, that's my impression from the periphery, and I think people we always talk about the cure for cancer, but the cures for cancer are being developed today. I think, and you can see them out there. They're not invisible. They're not far away in another solar system. They are there. And I think we have a lot of good news we're going to be giving people over the next decade, and have some today. So thank you so much for joining us. That's all we have time for right now. My guest was Dr. Richard Frank, and I want to thank him. If you have questions you'd like to send to us or comments, please email them to me at healthtalk@newvancehealth.org. I'd love to hear from you, and I'll see you next time.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.